and role of endoscopic imaging in pediatric IBD patients will be lectured by Professor Marla Dubinsky and moderated by Professor Supon Tripong Karuna, the president of the APPSGHAN. So before we start, let me remind you again about the chat box. If you have any questions, please feel free to leave them in the chat box, and we will try to answer them back in the chat box and through your email. For the on-site participants, so please write down your questions and emails, then submit them to our coordinators. So I would like to ask you to welcome the next lecture by Professor Marla Dubinsky.
Welcome to the PIBD Symposium. Today we have an interesting topic on treat to target and the role of endoscopic imaging in pediatric IBD patients. This lecture is sponsored by Johnson & Johnson Southeast Asia. It is my honor to introduce Professor Marla Dubinsky. Dr. Dubinsky is a professor of pediatrics and medicine at IBD School of Medicine. She is currently a chief of pediatric gastroenterology and nutrition at Department of Pediatrics and a director of the Susan and Leonard Feinstein IBD Clinical Center at the Mount Sinai Hospital in the United States. Her primary research focuses on the influence of genetics and immune responses on the variability in clinical presentations and prognostic outcomes, as well as therapeutic drug monitoring and positioning of IBD treatment. She is also interested in the impact of IBD on fertility and pregnancy. Professor Dubinsky is the co-founder of We Care in IBD, an organization dedicated to the health of women with IBD. She has lectured widely nationally and internationally and has more than 260 publications in many outstanding peer-reviewed journals. Today, she will give a lecture on treat to target and the role of endoscopic imaging in pediatric IBD patients. Ladies and gentlemen, please welcome Professor Marla Dubinsky.
Thank you so much, Professor Suporn, and I'm excited to be here to review again treat to target and the role of endoscopic imaging in pediatric IBD patients. Treating to target is a very important topic of late, as we are all trying to figure out how to best introduce specifically advanced therapies into our practice and the timing of which, and whether or not we can actually alter the natural history of pediatric IBD, but IBD in general. Here are my disclosures. So we will discuss the treat to target approach in pediatric IBD and how this actually applies in real life practice, discuss the clinical benefits to apply a treat to target concept into IBD management, and in the Q&A, illustrate the role of endoscopic imaging to evaluate treatment outcome with advanced therapies. So we know that over time, when we look at the natural history of inflammatory bowel disease, this has particularly been shown in Crohn's disease, but I will highlight the fact that we are understanding more that ulcerative colitis also has transmural or bowel wall damage over time due to just rigidity and loss of compliance of the colon, as we know about chronic inflammation. So our whole sort of theory around decreasing the rate of surgeries, the rate of complications over time in IBD patients was to be able to actually get bowel wall healing, or this concept of least of mucosal healing. Now, interestingly, the definition of mucosal healing has also been changed as it relates to the regulators, meaning those who are approving drugs. They've actually redefined mucosal healing to include histology, as well as what we view as endoscopic remission, for example, on endoscopy. And really the question is, can we achieve transmural healing, and therefore should we advance beyond just mucosal healing? So these are sort of the discussions that are happening at a high level as it relates to what is our treatment target. The treat to target and tight control paradigm, because it's interesting, once you've achieved your target, you then need to keep that target in tight control. So it's hard to separate tight control outside of treat to target, but in a way you sort of use biomarkers or this ability to actually monitor your patient along the way, achieve a target, and then keep them at that target. So it really involves predefining what target you're treating for. There's, clinical target, there's biomarker target, there's radiologic, there's mucosal, transmural, there's even therapeutic drug levels, etc., whatever our target is, and continuously monitor that patient and modify the treatment until that target is reached. There has been plenty of sort of algorithms that have put out there, and essentially it's, you have IBD, you test, have you reached your target? If not, you will continue to optimize, and then did you reach your target? Yes, no. And it's this continual iteration of being able to decide at which point have I reached the target, and therefore once you have, how do I keep it there, and what are the outcomes that I'm actually targeting? And mucosal healing, clinical, as I mentioned, quality of life, target of urgency is now a big deal in ulcerative colitis, and some of the newer therapies are actually looking at specifically bowel urgency as a new target for drug treatment with ulcerative colitis as well as Crohn's, but specifically in UC, which is really exciting because our current clinical disease activity indices actually, believe it or not, do not actually show whether or not we have actually met our target urgency. It's just stool frequency and rectal bleeding, for example, for ulcerative colitis, yet some of the outcomes that keep patients up at night, for example, the outcomes that really matter to our patients are often not things that we're actually monitoring in clinical trials. So there's an evolution of what our targets need to be, and whatever it is, our therapies need to be able to reach it. So we sort of look at the STRIDE-2 guidelines as being sort of where we live as it relates to a treat to target strategy. And since the first author is a pediatrician, Dan Turner, just as a historical perspective, the International Organization of Inflammatory Bowel Disease, or IOIBD, first presented STRIDE-1 guidelines back in 2015. And interestingly, at that time, there was no growth as a target, meaning pediatric outcomes were not sort of integrated into that treat to target algorithm. And back in the day, because these guidance are actually based on literature, in 2015, CRP and Calpro had not been evaluated enough as a target for which we should actually change treatment based on that. It was just viewed as a surrogate, something you do in addition to endoscopy to be able to actually say, all right, your Calpro's up, you should scope. Well, now the STRIDE-2 guidelines said, no, there's enough data to say that you can actually optimize based on an intermediate target of a biomarker, and you don't need to scope to confirm that your calprotectin actually represents what's going on endoscopically. As well as this idea that at sort of a year, the goal is to reach mucosal healing and normalization and absence of disability. So we've set the bar that our therapies now, even 6 years, 7 years later from, actually it was 6 years later from the earlier STRIDE-1 guidance, which we actually said we can actually use symptoms as a short-term goal. We want to normalize our biomarkers, and then we want to have endoscopic healing. And interestingly, for future targets, this concept of transmural healing as well as histologic healing. So you can see laid out here as to where our goals are on our targets. Now, there was a recent publication in Pediatrics similarly guiding us on where we need to go as it relates to pediatrics. Here too, they said within this 3 to 6 months, you'd want to get clinical as well as a biomarker change or improvement or healing. And then in the 6 to 9 month period, we should be thinking about not only clinical in the short term, but also thinking about endoscopy as an outcome for pediatric treat to target. And the STRIDE-2, as I noted, did start to implement a lot of pediatrics into the concepts of growth. And here again, this concept of if we are treating to mucosal healing at the time, whatever we're defining it as, that we are actually changing the natural history of the disease. And I remember having similar discussions that we're having now about transmural healing and histohealing, whether that's even possible. We had this discussion about mucosal healing because all we were doing was treating to symptomatic remission. And now we're at a point where we actually have this concept that we understand that symptomatic remission is not enough. So the question is going to be, which is posed to everyone looking at transmural healing and histologic healing as the next level or the next frontier, is whether or not outcomes that you would get by not only having endoscopic remission or healing, but you would also have histo or transmural, is whether or not you would get even better long-term outcomes than endoscopic remission alone. And that's going to be the big focus over the next 5 years, is to say, is endo healing not enough? Meaning endoscopically, is that not enough? And if it isn't enough, what do we need to do, and how accurate does histo or transmural reflect our ultimate goal? So that, I would say, is like the tip of the iceberg, and we're sort of just dabbling in what that means from a long-term perspective. Now, ECHO and APPSGHAN came out with sort of this concept of treat to target, but actually felt that you should first risk stratify patients into those that are high versus low risk, and define that clinically using the Paris classification, for example, and therefore dividing up into saying, well, if it's purely inflammatory, there's no complicating disease, and there's no deep colonic ulcers, or there's no extensive disease like pancolitis, then our feeling is that you could start with maybe EEN as a bridge to thiopurines, for example. What I can tell you, in North America, we no longer do what's on the left. We do not use something as a bridge to thiopurines. Pretty well, we've adopted the philosophy that in pediatric patients, the risk of thiopurines outweigh the risks of using advanced therapies like anti-TNF. And so therefore, this risk stratification comes down to really what the payer or the insurance or the government would actually pay for, whether or not you can go straight to an advanced therapy or not. But pretty well in the US, we've stopped using thiopurines. Some still use methotrexate. So pretty well, I would have to say that in the US, we're not necessarily using this algorithm to decide whether they should go with a thiopurine-based maintenance strategy versus a biologic. If anything, we're just deciding now which biologic in pediatrics we should go with. And on the right, in the same paper, they identified what are sort of visions of high risk. And to be honest, some would say, if you look at some of the clinical attributes that have been tied to risk, some would actually say that just pediatric onset IBD alone is enough of a risk factor to actually say that you should be escalating therapy. So I'll be interested to see how the team is using advanced therapies, and whether you are using a risk-based strategy to decide what your target is, one, and what therapy you use at first to achieve that target. So a more recent publication in Gastro started looking again, saying, is there a way to sort of even risk stratify, suggesting here that any pediatric patient with small bowel disease actually would render them moderate risk, and really this idea of using maybe dietary plus a TNF, even the concept of, if you have very isolated terminal ileal disease, that you would even consider primary resection. And I'd be interested to know whether or not that's a philosophical or cultural adoption that Professor Suporn and her team have actually undertaken, as well as this concept of severe disease. So I think there is this attempt to try and risk stratify to determine where a patient falls. However, one thing that I note is, no matter what strategy we use, whether we risk stratify or not, you must pick a target, and the target today is symptoms plus biomarkers, with the ultimate goal right now of mucosal healing. Interestingly, there have been multiple publications. This is a review where they took all the publications out there that have actually been looking at mucosal healing as a target. So in this column here, it shows you what the targets have been, both histologic healing as well as mucosal healing, and looking at whether or not there was a better achievement of outcomes of minimizing complications tied to achieving a target. So although there's not a lot of guidance necessarily on whether or not outcomes have changed, there is some increasing publications that have definitively looked at these different outcomes to see whether or not you do get better long-term outcomes, because we're not talking short-term when we talk about the goal of achieving mucosal healing. What we are talking about is whether or not in the long term, we actually reduce the rates of surgery, complications, hospitalizations for our patients by achieving a target beyond just clinical improvement. And one of the most important studies, I think, of late is the CALM study. Now, the CALM study was, as a reminder, is a study where it was a AbbVie-sponsored global study where they randomized patients to receive adalimumab, and using escalation of adalimumab based on clinical symptoms alone, versus the other arm, which was called the tight control arm, which were patients whose adalimumab was escalated based on CRP and or calpro, regardless of how the patient felt. So this was one of the first studies to actually say, you know, you need to be looking at objective evidence, not just clinical symptoms, to escalate the drug to be able to achieve a target of mucosal healing. Now, the second part of the study is really important, because what they showed is that at 1 year, someone was in deep remission. They had a much better outcome with reduction of surgeries, hospitalizations, and complications by such a significant amount, 81, in a sense, of 81% drop in your hazard ratio of developing a complication if at 1 year you were free of ulcerations. So this was the first study to actually show that when you achieve a target early, you actually change the natural history of Crohn's disease. So why we say achieving remission, deep remission, which includes clinical biomarkers and endoscopic healing, was important at changing the natural history. So this is from my advanced fellow. We're submitting this to APPSGHAN, so you're the first to actually see this, is the idea that we went back to our pediatric patients and looked at the natural history, sort of mimic CALM, to see whether or not the outcome of mucosal healing at a treat to target colonoscopy actually resulted in better long-term outcomes in pediatric patients. And we had over 350 patients that we looked at who started infliximab or adalimumab, and this is just the demographics. And you can see here that there was about 60% of patients were adalimumab treated, 40% infliximab. This is at Mount Sinai, all comers of patients who started an anti-TNF. And here you can see that we have the majority of our patients are ileocolonic Crohn's, which is quite typical for pediatrics. The majority were Crohn's disease patients, a smaller minority were UC or IBD-U. Duration of disease duration at the time we started a biologic, which shows you we do not risk stratify, it was half a year. It was 6 months. That was the median time to starting a biologic at Mount Sinai. So it sticks with what I said, that we don't typically risk stratify per se. And what we were able to show is we were able to mimic what we saw in the CALM study, that there was such a significant reduction in complication and surgery in those patients who achieve mucosal healing, which is the blue graph, compared to, over time, those who did not have mucosal healing at the time of their first endoscopy. More importantly, we looked at the fact that if you didn't have mucosal healing, but you treatment optimized, at least at that first endoscopy, we were actually able to recapture 40% of patients 60% of patients did not end up going to complication or surgery, versus those, if you don't have mucosal healing and you don't optimize their dosing or you don't switch them to something else, almost everybody went on to complication. So what this told us is that mucosal healing as your treat to target in pediatrics is critical to changing the natural history of the disease. Now that was using endoscopy. This was another study that looked at using capsule endoscopy, where they actually used capsule to determine that the patient did or did not achieve healing. They escalated or optimized or changed therapy. They were able to get more patients into remission, with the idea that at the end of the day, they were able to accomplish that 42 out of 53 patients maintain clinical remission at a year. They were able to get 28 with complete mucosal healing by optimizing therapy, and 10 partial mucosal healing. But the idea is whatever modality you use, you must treatment optimize if you are not reaching your target along the way. So I think it's really important that if you're going to evaluate at 6 months, for example, particularly using capsule, or if you're going to use endoscopy, is that you need to be prepared to do something. Now, this new concept of interest is this idea of disease clearance. So we keep raising the bar as to what we think we can actually do and what our therapies think we can do. And this is a concept of being able to clear the disease histologically and transmurally. So maybe the redefined target is not just mucosa or clinical, but it's actually going to be able to actually achieve complete biomarker normalization, histologic healing, and no transmural inflammation. So this is where folks are moving. And again, maybe disease clearance is going to be our new sort of terminology. So stay tuned for what the next frontier of what we mean by our target. And the question, they studied this in pediatrics to see whether or not there are various factors that may actually predict what's going to happen in terms of mucosal healing and histologic healing, meaning are there baseline things we should know about pediatric patients that can help us understand? To be honest, they haven't been able to look at various ways to suggest that one thing over another is able to predict who's going to get to healing. I think probably one of the things they were missing in this predictor is drug concentrations, because to be honest, probably one of the most important predictors of using a TNF as to whether or not you're going to achieve mucosal or histo healing is actually whether or not you've reached enough drug target if you're going to use advanced therapy. So that's for another discussion. So what I want to introduce is the concept of bowel wall ultrasound, intestinal ultrasound, and whether or not, I'm not sure that's being implemented. I'm dying to hear if that has sort of been prime time and is at the clinic, this bedside ultrasound. But we've started integrating ultrasound as part of our type control strategy to be able to use it as a target along the way to try and maximize our ability to reach mucosal healing at a year. And this is just showing you this extensive bowel wall thickness, which is 6.3 millimeters, normal in the terminal ileum being less than 3. Here's hyperemia. Here's an image of the exact same using MR enterography, and here's what the capsule looked like. So this is showing you lined up against each other what our various imaging looks like when it comes to determining active inflammation. Now, there's been a lot of studies that have shown that you can use ultrasound as a tight control along the way, meaning that you should be using ultrasound like you would use calprotectin or CRP as an intermediate goal to be able to actually increase or optimize therapy, so that if you can look at it as a role to actually say that if I start off in certain, if I can actually use ultrasound and optimize my therapy along the way so that I can reach my target. This has been shown in Crohn's, and you see that you can use ultrasound as a way to actually use it as tight control to get to your target, and then use ultrasound as tight control to keep your patient in endoscopic remission. Even for acute severe UC, you can actually show that your patient matches endoscopically, and you can see whether or not in the hospital that this patient is actually achieving any improvement in outcomes with whatever advanced therapy you use. This is a patient who actually 6 weeks after using steroids and infliximab, you were able to see that the patient had a response, and therefore using that as now the way you're going to keep your patient well and track them to reach their outcome of mucosal healing. So, summary of T2T in pediatrics, we know that treating to mucosal healing is associated with improved long-term outcomes. Treatment optimization is the key on treat to target if mucosal healing has not been achieved. Intestinal ultrasound can improve tight control monitoring, and transmural healing is possible and should be another level to target, and outcomes need to be assessed. So thank you so much for the opportunity to present. And I'm happy now to stop sharing my screen. And Professor Suporn, if we can start resuming some discussion around some of the topics that I highlighted today.
So you show us nicely on the imaging using radiologic, using ultrasound, intestinal ultrasound, ultrasonography. But I think in practical, only certain radiologists in some countries can perform the intestinal ultrasonography. And the MRE also have the limitation because it's required general anesthesia in young children. What would you suggest in the about the imaging in young children to assess the transmural inflammation and transmural healing?
To be honest, if we're just looking at mucosa and histology, then your endoscopy is going to be your, still is the gold standard, by the way. I think that what I would say is that ultrasound is good to monitor your patient on your journey to achieving mucosal healing right now. However, the only way you're going to know whether you're achieving transmural ultrasound is through cross-sectional imaging. And of course, we don't want to put patients through CTs because of the radiation exposure. So, and to be honest, we only give anesthesia to the very young patients. So I'm not sure what your age cutoff is for anesthesia for MR enterography. But what we've realized is, I think your ultimate sort of new guidance is going to be to try and get point of care ultrasound into the clinic for as many sites as you can, particularly in pediatrics, because you'll be able to actually see transmural healing and you can track it, right? So I think if that becomes the gold standard, which it looks like that's where the field is going, is trying to get transmural healing as part of this disease clearance story, I would say that you need, right now, transmural healing is not the North Star that we're going for. We're going for mucosal healing, so endoscopy still remains sort of your gold standard anyways. But if it's possible to start to integrate and get point of care ultrasound in the bigger clinics, I think it will advance your ability to optimize and get people onto advanced therapies much faster and be able to actually decrease the amount of MRs that you would need to do, especially in young kids, because that's where there's a real benefit. And also, over time, you don't want to keep scoping everybody. You'll be able to use your ultrasound to keep patients in control, right? Once you've achieved your mucosal healing, your ultrasound could keep them in tight control.
Okay, thank you so much to have the training course for the radiologists. To be familiar with this ultrasound. I think it's a good idea because this is non-invasive and is available everywhere. So
yeah, I mean, there's been just to let you know, there's been a big push. There is a society called the Intestinal Bowel Ultrasound Society, which was started in Europe. And it's the GIs, by the way, it's not the radiologists that are doing it at bedside. So I trained my fellow in Europe to have him go and train, and now he does it in the clinic. So I don't involve radiology, interestingly enough. So I don't know if that would work in your setting, but that's how it's been working.
Yeah. Okay, so another question is about the histological healing. I mean that according to the slide 2, histological healing is not necessary for the target. And some also suggest to have the histological healing. So what do you think about this?
Yeah, it's interesting. So every drug company right now, for all the new drugs that are coming out, and at DDW, that's what was shown, is that they've all included as part of a secondary endpoint, not primary. Histology is not included in the primary endpoints of the trials, but this combination of endoscopic improvement plus histologic remission, which means no neutrophils. And they've looked at it at week 12 as well as at week 52. And our drugs are able to do that. So what we're starting to see is that in trials, people are evaluating whether or not, one, that's achievable, and the answer is yes. It's not in everybody, but it's definitely achievable. And what folks are waiting for is whether or not histologic healing adds anything to decrease surgery, decrease anything, decrease colon cancer rates in UC, whatever the question is going to be, is right now we need to build the evidence to say that histohealing is better than endohealing alone, right? So meaning histo plus endo has a better long-term outcome than endoscopic healing alone. Until we have that, I don't think anyone is saying, wow, my patient feels perfect, their CalPro is perfect, but they actually still have some neutrophils, so I'm going to double my dose of a biologic. I'm giving you that as an example. People right now are not doing that. So I think we have to wait for more evidence to come down the pipe.
Thank you. Yeah. Another question is about the practical approach. In the patient with the chronic Crohn disease, if the target cannot be achieved with the infliximab therapy, despite the immunomodulator and adequate TDM, so the next biologic, which one would you suggest, vedolizumab or ustekinumab?
So this is, I'll give you my sort of algorithm in my head. So, and this is also based on some of the newer meta-analyses that have come out. There's network meta-analyses that have been published, although they're not head-to-head, because, you know, we just don't have that ability to have all these head-to-head trials, is that we're doing sort of these network meta-analysis where you try and do some matching for patients that go into trials. And what they've shown is that in TNF failures, which is our biggest issue, right? Because we're really struggling with what comes second. I think we're all very good at deciding what comes first, but the problem is what comes second. So this is what we know, is that I'll divide up Crohn's versus UC, okay? So first taking UC, because that's actually an easier answer, is that it appears that ustekinumab and JAK inhibitors, although it's not neither approved for peds, right? We're talking tofacitinib or upadacitinib, which, by the way, we have approved for UC for adults since March. So we have 2 JAK inhibitors. We have ozanimod, which is an S1P receptor modulator that has been approved in adults with UC in the US for a year now. We have Veto, we have ustekinumab, and we have the TNF. So we've got, you know, a vast majority of toys. Unfortunately, we don't know how to play with them yet, so we're trying to figure out what comes second if I failed TNF. So what we do know is that the JAK inhibitors for UC, the JAK inhibitors and ustekinumab appear to do as well in TNF failures as in TNF naive for UC. Vedolizumab does not, and adalimumab does not if you failed infliximab. So there's no role, to be fair, there's a role. Of course, the person sitting in front of you, the case will change, but I'm giving you general statements based on data, is that in patients who are failing TNF, it is either going to be ustekinumab or a JAK inhibitor for UC, okay? So that's the statement. For Crohn's disease, similarly, for sure vedolizumab, it appears that if you failed 1 or 2 TNFs, it's not going to be effective for Crohn's disease. We have it approved for both Crohn's and UC. Ustekinumab is about 50% less effective in Crohn's if you have failed a TNF. It's not like it is in UC. And also upadacitinib, which is not approved for Crohn's yet, but the phase 3 data was presented at DDW and at ECHO, shows that upadacitinib is agnostic to whether it works in failure. So because it's not available yet, we cannot be using it at the moment for Crohn's disease. So really, it looks like our best bet for TNF failure is ustekinumab today. Now, in June, we're going to have risankizumab, which is an IL-23 only. So reminder that ustekinumab is 12 and 23. It blocks 2 interleukins. Risankizumab blocks only the 23. And up to 20% of patients in the risankizumab adult trial were ustekinumab failures. and it does look like it may have a signal in that. So we're excited to see whether or not we can even use risankizumab in ustekinumab failures, but for sure it was effective in TNF failures. So it looks like in Crohn's disease, it's pretty simple. You fail TNF, you're going to go to a 12/23 or a 23, depending on what you have available. And upadacitinib will be available as well once it gets approved for Crohn's disease. So that's in Crohn's. In ulcerative colitis, you have a lot more options, but ustekinumab and JAK inhibitors would be your best bet. So vedolizumab role is first line, is its best positioning, particularly for ulcerative colitis. So if you have a moderate patient who would benefit from vedolizumab, that is my favorite drug for moderate ulcerative colitis.
Okay.
Okay.
Okay, thank you so much. So very updated information, and we need to wait for also update for the new information to come.
Yeah.
Thank you very much, Professor Dubinsky, for the informative lecture and fruitful discussion.